I've been asked to talk about all of the above, the whole body, in 20 minutes. So these are my disclosures. I do some work for Siemens and Janssen Pharmaceuticals. Now let's start with the case history. Here's a patient that presents to you typically. The patient's got breast cancer on the left, has a margin positive excision, has DCIS on the right side, has margin positivity, but she can still be cured, quotes and quotes. She needs a double mastectomy. The surgeon says, well, maybe we better do a staging scan. And what do? They do a bone scan, and this is what it looked like. You see two lesions. The radiologist calls this metastatic disease, says she's going to die, and that's it. Now, what are you going to do? You're the clinician in charge. I know most of you are physicists. Are you going to do a CT scan to clarify this? Are you going to do a whole body MRI scan, which is, of course, the right answer? You're in a whole body MRI session. You could say these are normal. Just go for a double mastectomy, send her home, she'll be fine. Do you say she's going to die no matter what you do? She needs palliative chemotherapy. Or as a physicist, are you going to take option 5 and say, this is not my problem? Right? So, of course, it became my problem, and we did a whole body MRI scan, and here is just the MIP projection. And here's the postoperative change, breast, in the axilla with the biopsy. Here's the breast. This is the T2 shining through for the other breast. And you see all of these lesions. They're all metastases. So unfortunately, and they were confirmed by the CT scan, you could see a couple of lytic lesions there. There's another one over there. There's another one over there. So unfortunately for this woman, this is not cure. The prognostic, actually, you've probably got about 5 years. So you've gone from a complete cure to a death sentence, essentially, in 5 years' time. And, and that has profound implications. And that scan did that. Now, diffusion imaging, the MIP image is certainly a signal intensity-based tool, and I agree with the previous speaker that the signal intensity is important. The signal intensity is clearly related to high cellularity, impaired diffusion, and that's what causes that high signal that you see. And like the previous speaker, I think ADC is more useful for lesion characterization, which is what you've been hearing about, the difference between FNH, adenoma, all of that kind of stuff that you've been hearing today. And actually it's very useful for therapy assessment, which is what we're going to talk about tomorrow. So if you were to do different patients and look at what typical appearances are, it would look a bit like this. So here's a normal woman. Here's clear cell melanoma, prostate, myeloma, breast. And if you normalize the images across from left to right, you'll see that melanoma and breast metastases are the brightest. Prostates tend to be less bright. Melanoma, because of susceptibility, can sometimes be not that bright. And renal cancers, because they often contain fat and necrosis, can have actually slightly lower signal intensity. So here, for example, is a metastasis. Here's the primary tumor. And if you just did the measurement, just did a signal to background measurement, you'll see that there are real differences between yellow marrow and mixed red marrow compared to different tumors, but myeloma and breast certainly seem to be the brightest lesions on whole body diffusion scans. Now, where is the evidence that this stuff actually works and is better than other techniques? Well, we know that whole body MRI, so that's a diffusion MRI plus the morphological sequences which Mu discussed yesterday, does detect more lesions, more malignant lesions and fewer benign lesions compared to bone scans. So those of you who are using bone scans, please stop. Here, for example, is a single lesion in a woman with breast cancer, and there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 lesions, if you count very quickly, in this lady with breast cancer. So we see one lesion with bone scans, BS, bone scan or bullshit lesions, but you can see a lot more with whole body diffusion imaging. And if you look at this lady, she actually does, if you look at it carefully, the advantage is you'll be able to see other things. So you're not restricted to bone, you'll be able to see soft tissue. So here's the bone lesion, and here's the liver metastasis that wasn't called on this CT scan It's not the best CT scan in the world, but this is what happens in real life. Sometimes it looks like this, and this was read as normal, but actually you can see the patient has metastatic liver disease. Makes a big difference because you've gone from a hormonal therapy to a chemotherapy. That's how big that difference is. So spotting that visceral metastasis makes a difference in terms of what happens to this woman, and she does fine. Actually, she's still alive. You can see her as you go along in time, all the lesions resolve, and then once the chemo finishes and the first follow-up is shown here, you can see that the bone marrow, the background bone marrow, is beginning to come back as the hyperplasia occurs in the background. So she's actually doing fine at the moment. Okay, now there's no doubt that this whole body MRI technique does better than bone scans and targeted X-rays and performs as well as CT scans in prostate cancer also. And this was shown very nicely by this study that was published in 2012 by Frederic Lecouvé, who showed very convincingly in high-risk prostate cancer that if you have a negative, if you're high risk and you have a negative MRI bone scan, and there were 55 patients with a negative bone scan, you would have said to them, "You'll be fine. You're cured. We can cure you. There's nothing wrong." Well, actually, depending on the reader, there were 7 to 8 out of those 55 patients who had metastatic disease. So in fact, were put into a bad prognostic category, and they would conventionally not be called today. And this is very important, and here is just an illustration, another illustration. So you can see nothing here in the spine on a planar bone scan. There it is on the whole body MRI scan with the diffusion scan showing a couple of lesions. There's no doubt that in fact the overall performance of an FDG PET and a whole body MRI scan are probably about the same, and both are better than CT and bone scans for bone disease. There's no doubt about it. And here is an example of somebody with small cell cancer. Here is the B900 image. Here's the fluorine PET done on the same day. This is a bone scan that was done on the day before, and you can see that clearly the B900 image, the FDG PET scan, outperform the bone scan, which is now quite obvious to you, but in fact the performance of the two in terms of the distribution of the lesions is actually very, very similar, and we'll come back to this particular patient later. And a meta-analysis published a few years ago quite nicely showed that. So I'll just show you the ROC curves, which quite nicely illustrate the performance of FDG PET for detecting bone disease. There's whole body MRI scan. This is CT scan, so you can see the sensitivity is lower, specificity is quite high, but this is what we're using in the clinic. So please stop using bone scans. Now, that's also been shown with a specific tracer for prostate cancer, so choline PET versus MRI versus bone scans. And again, another meta-analysis that was published quite recently, and you can see again, this is FCH, fluorocholine PET scans. This is whole body MRI scans, actually doing slightly better in terms of sensitivity. But here is bone scans. Please stop using bone scans. Okay, now, it turns out that there are lesions which we will not see on a whole body MRI, on a whole body diffusion scan. There will be lesions like that. And these are the osteoblastic metastases. So here's a very nice example of bone scan positive, CT scan positive. This is clearly a metastasis. You do the diffusion scan and you don't see it. Okay? So it's a sclerotic lesion that you don't see, but clearly you need the morphology. If you have the morphology, this is easy, right? So you do need that morphology. You can't just do the whole body diffusion scans. Now, you mustn't go away thinking that sclerotic lesions are all negative on whole body diffusion scans. So here, for example, is a completely sclerotic bone. I mean, it's just stuffed full of sclerosis. Here's the PET scan, which is negative. Here is the diffusion scan, which is positive. And it's very interesting when you look at the sclerosis. But in fact, if you look very carefully and you magnify it out, you can see that there are spaces here within the sclerotic bone where the cellular tissue is sitting and is able to give you that high signal intensity. So looking at images like this, you can actually determine the best scan to monitor this particular patient is going to be diffusion imaging rather than the PET imaging, because the PET imaging in this particular instance was negative. Okay. Now, what about diffusion imaging alone against FDG PET CT alone? Well, it turns out that the performance is actually pretty similar. So here's a study, another meta-analysis that was published recently. And what they did was just said, let's look at the diffusion imaging alone in a whole body sense, and then a whole body PET CT, right? So we're strapping ourselves, we're saying we're not going to use the morphological imaging, we're just going to use the diffusion component. And in fact, it turns out that the performance of the whole body diffusion imaging and the whole body PET imaging is actually pretty similar. So this is an essential component of the whole body MRI scan. So don't do whole body MRI scans and leave the diffusion out, which is what Moo said to you yesterday. Right? Make sure it's there. It's an integral component. It is right there. You can't leave it out. And this is why it's integrated into all our protocols. Now, clearly, the performance of the techniques will depend on the primary tumor and on anatomical locations. So if you were to look at this patient with the small cell lung cancer again, you'll see that there are times when the PET will be better, and there are times when the diffusion will be better. So, for example, if you were to look at this lesion here, a para-aortic lymph node, sorry, a paratracheal lymph node, on a PET CT, that's positive, but on the diffusion scan, that is negative. All the other lesions pretty well match up. Even this little tiny lesion here, this lesion here, this lesion here, this lesion here. But look at this lesion over here. Now, on the diffusion, this is a normal-sized lymph node, so you'd call it negative. This is just, we know that you can have normal-sized lymph nodes that will be hyper-intense on the high B-value image, but clearly, this is a fatty-containing axillary lymph node. This is not malignant. And if you go through the rest of the scan, you'll see here, for example, is cardiac uptake on an FDG PET scan, which is normal, which of course is going to be negative on a whole body diffusion scan. And if you look over here, for example, there's a metastasis in a bone, which is negative on the diffusion scan. And if you were to look at the PET scan, you'll see here you can see only 2 lesions. And if you look over here, you can see there are actually probably 2 or 3 lesions right next to each other. So there is clearly complementarity and differences as you go through these scans. Okay, now some of you will say, why the hell does it matter? You got 1 MET, you got 10 METs, so what, right? Why does it matter? Well, actually it does. And the reason it matters, and this is just laid out over here, is we know that the presence of disease precludes curative treatment. So that's the first thing. If you see anything, this patient isn't curable. Number 2, we know that if you have small volume disease, oligometastatic disease, there are opportunities to treat focally to postpone systemic therapies which may follow later. And that is a real opportunity that's being realized in prostate cancer. But we know that in advanced disease, in other words, if you've got more than 5 metastases, for example, in prostate cancer, the burden and the distribution are highly prognostic and affect therapy choices. Highly prognostic and affect therapy choices. And I just wanted to show you evidence of that. So the shorter the duration from when you suspect a prostate cancer is coming back to the time at which imaging sees the prostate cancer, the shorter the time interval, the worse that patient will do. Right? So it behoves you to find the cancers early because that picks out the bad players. We know that every doubling of volume in a bone scan halves the patient's life expectancy. Every doubling of volume halves the patient's life. The other interesting thing is that if you have high volume disease, right, so you've got more than 5 metastases, and we're talking about prostate cancer at the moment, this puts patients into a very bad category. And there's this study called Charted, which is just about to be published, shows that very clearly. So volume and distribution of disease is very, very important. We also know that if you treat at lower burdens of disease, if you intervene at a lower burden of disease, you can get survival benefits. These survival benefits are with a number of treatments. Sipuleucel, which is an immunotherapy, abiraterone, enzalutamide, docetaxel, all kinds of treatment in prostate cancer. So finding that small volume disease and intervening early does result in longevity for these patients. Do you know that the distribution of disease also decides on whether you can or cannot have a particular treatment? So if you were going to get radium and you had visceral disease, you would be ruled out. So you want to be able to detect a particular patient and say, this guy is suitable for for radium, or this particular patient isn't. And the distribution of disease is important. We also know that the effectiveness of a treatment is directly dependent on the burden of disease. So if you were going to be treated with Sipuleucel T, which is like $150,000, that's how much a treatment costs, right? The smaller the burden of disease, the more effective it is. So if you show 20 metastases compared to one metastasis, then you can say, well, actually that patient with the one metastasis more likely to benefit from Sipuleucel T than somebody who's stuffed full of cancer. You would save $150,000 just by making that determination. Not only that, we also know that if you were going to treat with chemotherapy and androgen deprivation treatment, the larger the burden of disease, the more likely you are going to benefit from a combination treatment than a single treatment. So if you have a large burden of disease, which is more than 5 mets, with at least one lesion in one of your appendages, or if you have lung or liver metastases, those patients will benefit more from a combination therapy than a single treatment. So you can see how distribution, volume, and detection of disease is really very, very important. Now, if you did whole body MRI scans, then this is what would happen to your activity. So this is my activity between 2008 and December 2014. And you can see that I'm doing between 80 and 100 scans a month. So you have to be careful if you're going to go down this route, because actually there's a lot of work here for you if this is what you want to do. Now, what sort of patients am I seeing? I'm seeing patients when other stuff doesn't work. Other stuff being X-rays, for example, for multiple myeloma. They still do it, standard of care. Whole body X-rays to decide whether a patient gets treated or not for multiple myeloma. Bone scans sometimes don't work very well for prostate and breast cancers, and we know that CT scans sometimes don't work very well indeed, particularly when you've had previous therapies. So if you've had previous therapies, you've got disease that's alive, disease that's dead, disease that's new, disease that's old, that becomes a real mess, a real difficulty for us. And in fact, this whole body MRI scan can be very useful. And there are times when conventional markers of response don't work. So PSA, for example, in the castrate-resistant state, doesn't work. CA125 in breast cancer, nobody uses because it doesn't work. You have oligosecretory disease in multiple myeloma. What are you going to do for these patients? Right? You need to be able to meet these patients' needs. So we use it for high-risk prostate cancer and high-risk breast cancer. High-risk prostate cancer, we use it to replace bone scans and CT scans, and if it's negative and we are still really suspicious, we only go to the choline PET afterwards. We think this is a better way of using precious resources. Now, in breast cancer, there's a group of patients who do benefit from early detection of metastatic disease. And these are the very high-risk patients, which are these patients here with more than 4 lymph nodes, your triple negatives or HER2-positive locally advanced breast cancers. And in them, what we do is we want to replace, again, CT scans and PET scans for these particular patients. Now, so just to show you a couple of examples, here's a patient with a locally advanced breast cancer. You can see axillary lymph nodes at level 1, and no metastatic disease, and everything else looks fine. Here's a patient with a small lesion in her left breast, but large numbers of lymph nodes in the left supraclavicular fossa. Bone scan was normal, but the whole body MRI scan clearly shows that she has metastatic disease in her bone marrow. So in fact, she has much more advanced disease than you were expecting. We also use it for response assessments. And response assessment when the disease is mostly in the bone. In the bone, it's a really tough area. So this is an area that I would encourage you to look at. So here's a patient with breast cancer. You can see she's got triple negative disease. She gets treated with the first treatment. She progresses. We change treatment on the basis of the MRI. We change treatment on the basis of the MRI, and then she responds. So we're using imaging, and she's got liver disease. You can see she's got lung disease. She's got kidney disease. She's got disease all over the place. And we are using diffusion imaging to make that determination. So I've tried to show you that this whole body application will replace current methods. I don't think there's any doubt about it. In a lot of centers it already is, but diffusion imaging isn't the only answer. It's going to have to be multimodal. It's going to have to be MRI PET, it's going to be MRI CT. We are going to have to look at other wet biomarkers also. There's a real potential to change the way the clinicians think about their patients, and particularly in the response area, which we will discuss in more detail. But we have to remember, there is no evidence that we have impacted on disease outcomes in patients today. There is still no evidence. You can't say, you use this strategy, this patient will live longer with whole body MRI. So we haven't answered that particular question, and clearly there are needs that we need to address, which is better software, knowledge gaps that we need to fill, and prospective clinical trials. Thank you very much indeed.